So he went through tips, and I sort of want to talk about tools for reduction. Just as a follow-up, this is the patient that he showed sort of a midpoint, and in the image in the center here, you can see our images from yesterday afternoon where we've got the external fixator on, we've got a medially based pin, we've got an anterior and laterally based pin, and then that central pin pushing and translating the shaft over. You can see a clamp there at the very bottom left-hand side of the image where I'm just getting the oblique fracture to line up a little bit better, and then the nail slips down in between all of that. So some strategic placement. This was Paul Gladden et al. From JOT, November of 2020, the nailable external fixation construct that he wrote up. And it's really nice using that sort of thinking all the way through your steps to where you're going to be. So a nice real world example here. So my tips for getting a reduction: first, you got to know if you get a reduction. So imaging is so critical. So positioning the patient ahead of time, that might be different if they've got an external fixator on. It might be different if they have joint contractures or other problems. And then really looking at the images ahead of time to know if this person has a lot of torsion of their femur, if the pelvis is if they're very lordotic in their lumbar spine, you're going to need a very wonky direction. So really tweaking the x-rays until you've got a good x-ray. The next thing is recognizing that you don't have a good reduction. And I think John probably showed some really nice images where hopefully people were looking at the images before he corrected it, and you're saying, I would accept that. I don't even see the problem. And the key is getting to the point where you know what the normal is and you know what perfect is, so you can be comfortable that it's not reduced. And the last one I said is OR before IF, right? So the open reduction part is why we're all here. It's not about the fixation. So just get comfortable saying, if you look at good imaging and you recognize that it's malreduced, get comfortable saying it's not reduced or it's malreduced. Now, it might not be so malreduced that you decide to address that somehow. It might not be so malreduced that you feel you need blocking screws. But if you never say it's malreduced, then you're never going to pull the trigger on opening up the distractor or putting in blocking wires. So some of the tips are just overcoming the inertia we have as surgeons to say, like, okay, moving on, moving on, moving on. You got to really take the time to look at your images and make sure you love them before you go to the next step, because sometimes you can burn bridges or at least make going back a little tougher. He talked about some of these modified clamps. These are actually commercially available now, although they're available with a pair of pliers and a little bit of elbow grease. But you can get them, and where we talk about, so the curved left and right would be the typical pointed small Weber reduction clamp. And then if you modify one side, and because the clamps have a little bit of enantiomerism, they're chiral. If you have the straight one on the left versus the straight one on the right, it's not the same as just flipping the clamp over. And then I prefer the speed lock, spin down kinds. Being a left-handed person, the ratchet becomes a big pain in my rear, so I prefer the speed locks. But everyone has their preference. You can get these commercially available. You can manufacture them in your own backyard. Thought I'd show a couple of cases. John took all the tibia stuff, so I'd show some femur. This is a 21-year-old kid with an industrial accident. His arm got caught in the mandrel. He had a traumatic amputation, and then he kind of got wrapped up around the mandrel, and so he had bilateral and proximal femur fractures. And what you can see here is I did an open reduction for this high-energy subtroch fracture, and you can see the large Weber clamp holding that reduced, and that's in drill holes, both reducing the varus displacement, but also the apex anterior, the flexion moment brought on by the iliopsoas. So using a clamp in order to maintain that reduction, and then nailed in position, and I was really happy with the result. Here it is, no clamps. You obtain the reduction, and then your implants maintain the reduction. Here's a lateral showing we've really got that flexion deformity out, and just enough that enough of a subtroch fracture down low enough that the nail was helping to maintain that reduction, but it's often in a little bit of flexion. This is a different patient, another high energy set of femur fractures. In this lateral view, you can see this patient was taken for external fixation a few days prior. He had an open femur on one side, and he had a closed femur on the other. So here we've got an external fixator maintaining position, and you can see that guide wire going in to the piriformis fossa with the X-Fix pin in the way. We took that X-Fix pin off and different kinds of clamps. So this is the clamp sampler. We've got a collinear clamp, which is an expensive tool, but it's really nice if you have it, especially if you're operating with fewer hands. The poor man's collinear is going to be a bone hook and a ball spike, but that takes 2 hands and a single person, versus this clamp you can just apply, set it, and forget it to an extent. It comes with different heads, so you can do either a low profile head, this high profile intra incision, or it's got a long arm that goes all the way around the limb. But I like this one for the femur. And then I'm using a large lobster claw down at the distal fracture for this segmental one. So John likes clamps, I like clamps. It really helps us reduce these nails, so that we can ream a reduced pathway and have no eccentric positioning. Here we are after. It's kind of even hard to see the fracture. It's just distal to the staple line, but very happy with the nail reducing it. And here we are post-op. You can't even see the proximal fracture really well. You can see the oblique fracture that I had clamped with the lobster down by that distal staple line. So really happy with clamps, taking the time to get a reduction before we start putting any metal inside as far as stabilizing implants. Here's the other side of that patient, a bit of a higher comminuted subtrope. So we did exactly the same idea, maybe not exactly the same way. So getting fixation where we can. My preference for a really proximal fracture line like this is I'd put it posterior to the majority of the canal. You can put it into the lesser. And that really allows you to get good fixation, but also pass a nail.
Thank you.
And then here we are in a lateral view showing we've reduced that flexion.
Oh yeah, he's a professor. He retired professor.
You can see that the lesser trochanter allows plenty of room in order to pass your nail in front of it. So it's really helpful for that. Here's that patient after fixation. So a couple of X-fixes, a couple of clamps, and it works pretty well. Finally, it's not just for the lower extremity, the superior extremity can get it too. So here we've got a nice high energy both bone forearm fracture, and you can see that straight clamp on the AP image on the right, going in through drill holes on the radial aspect in order to help reduce and maintain that compression. And then we went ahead and put a plate. And you can see sort of the sequelae of that, the drill holes on the radial cortex of the radius, maintaining that alignment. So that's what I got for images. I'm happy to discuss things. I think there's a lot of tricks there, but really what I would encourage you is to scrutinize your imaging and get to the point that you can admit when something's not well reduced, and then make a decision separate from that if you want to take the time and energy and biological insult to reduce it better.
James, that's outstanding. Both of you guys did a fantastic job, and I don't currently see any questions in the Q&A, but probably because it was a little bit more something to absorb, like all those pearls. And I think again, as a teaser to 2022, when somebody can be right there next to you, asking a question, it may pose some different opportunities. But if anyone does have a question for James, feel free to speak up on our panel, and I'll have Bridget give me control of the screen, which I'll share as soon as we confirm that there's no additional questions.
I think, kind of tying in and reflecting on what Dr. Gupta said is, these are skills that are learned through practice, and you can practice reduction techniques and clamp placement without being in the operating room, and figuring out sort of the obliquity and where kind of around the bone you want to grab it can be really helpful to think about that ahead of time, so that when you get a strange spiral or oblique fracture, it makes a lot of sense. John showed a nice image of a 3-dimensional reconstruction, so you can really trace that fracture line in your preoperative planning, so you know exactly where it's going to go from anterior to lateral, and where you can place that tine of the clamp so easily to get the reduction that you need.